Good afternoon, everyone, and thank you for joining us today. I'm Adalisa Perez, Director of Quality at the New Jersey Healthcare Quality Institute. The Quality Institute is a multi-stakeholder membership organization that convenes healthcare leaders in New Jersey around the common goal of improving the safety, quality, and affordability of healthcare for everyone. A public health crisis, such as the one we are facing now with COVID-19, tests our strengths and highlights our weaknesses. At the Quality Institute, we are going to continue having important conversations about today's toughest healthcare issues remotely through webinars, quality briefings, and other valuable resources such as this presentation. We will get through this together by communicating best practices and learning from each other. Just a quick couple of housekeeping items. Please know that the webinar is being recorded and a copy will be posted to our website at www.njhcqi.org later today. All phone lines will be muted for the duration of the program to limit background noise. You may ask questions at the end of the presentation by typing into the chat box. The topic for today's presentation is best practices for effective physical and mental telehealth visits. By the end of this webinar, you will learn how staff can be transitioned to telehealth, processes to consider when transitioning your practice to telehealth, how technology can meet several needs when delivering telehealth care, how to maintain confidentiality during a telehealth psychiatric or therapy session, what is telehealth consent, and how to be flexible about the changing standards of practice to adapt to client-patient needs. Please be advised it is not the intent of this program or its speakers to provide clinical or legal advice. Our speakers today for today's program are Quality Institute Board Member Kemi Ali, MD, CEO of the Henry J. Austin Health Center, and Tara Chalakani, PSYD, LPC, RN, Vice President of Mental Health Services for Youth and Families for Quality Institute, member Preferred Behavioral Health Group. And with that, I'd like to introduce our first speaker, Kemi Ali. Oh, Kemi, I think you're still muted.
Thank you. Good morning, everyone. So I will share my screen with you now. I am Dr. Ali, the CEO at Henry J. Austin Health Center. I've been providing services there for the last 22 years. I am a pediatrician by training, and I started my work at Henry J. Austin Health Center and practice on the floor for the first 10, 12 years of my tenure at Henry J. Austin. So for my discussion today, I want to highlight three areas to really think about as we discuss telehealth and transforming and transitioning our organizations to the telehealth world. So we'll look at the people, the processes that are necessary to be changed, as well as the technology that we really need to consider when we're thinking about telehealth. So telehealth, the people. Who are all the people that can work in this virtual world? So when we look at the staff that are needed, obviously there are call center individuals, so scheduling appointments, that can still happen remotely. Patient representatives, so those individuals that are registering patients. Nurses who are doing triage and screening, as well as providers. Providers are key in the medical decision-making. Medical assistants or community health workers, are they confirming visits and ensuring patients can access the system, as well as billing staff. So all of these individuals can be part of your telehealth world and work remotely. And in fact, at Henry J. Austin, we have about 200 individuals. That's a mixture of full-time employees, part-time employees, students, interns, volunteers, and we even have AmeriCorps Vista individuals. And again, that makes up about 200 people in all. 85% of those individuals right now are working from home for us. There are a small amount that are furloughed, in particular the dental departments, but the vast majority of all of our individuals are working from home, all the people that I've listed here. And when we look at the people, one of the things we've done is broken them out into teams. So their teams remain as if they were in the physical world. And so you can see here we have our provider remote team, and you have someone who's doing check-in. The BHC stands for our behavioral health consultant. So that's, or counselor, so that's the behavioral health person who's a part of that team, because we do practice integrated care. We have our nurse, and we have our MA, or our medical assistants. And sometimes you'll see in a team there's an other, and that's usually the patient navigator or the community health worker. So then the question may be, well, how do these people work remotely? So that gets us to our process. What are the processes that we put in place for these individuals to work in the telehealth world? So this is one example of the flow of how these individuals that I've mentioned, call center staff, patient representatives who are doing registration, behavioral health counselor, provider, nurse, medical assistant, how their roles and responsibilities are outlined in the telehealth world. And so this was mapped out so we can clearly see what each person's role, responsibility, and duties are remotely. So some other processes to think about are, how do staff communicate or meet with one another in this virtual world? So it was our practice to have our teams do morning huddles. So how do they do that remotely now? Are they doing it by text? We happen to use the Zoom platform, so our teams do their huddles by Zoom. Those teams that I just showed you on the previous slide. But there are other platforms out there that can be used as well. So again, thinking about how are staff going to communicate and meet with one another in this telehealth world. How does staff communicate with patients? Is it going to be through cell phones, or is it going to be through some other internet platform? We're thinking now about using Zoom Phone. So you can use Zoom Conference as we are right now, but you can also use the Zoom Phone technology, particularly when you're thinking about people like our registration staff, our call center staff. We really wouldn't want them using their personal cell phones to do this. So even if we can have the calls routed from our organization headquarters to individuals' homes, we don't want them using their individual landlines or cell phones. So again, thinking about how are they going to communicate with patients and doing the work they need to do. Again, there are many different examples, but a lot of these instruments, Zoom Phone, Google Voice, the nice thing about it is you get a dashboard. There's a platform where the manager can manage the calls coming in and out. The calls go out with your organization's number on it, so it looks just like it's coming from out of your organization, and it can be tracked and monitored quite easily. Other things to think about are, how do you share documents between the teams? So we were used to, in the physical world, handing a nurse, hey, here's the new policy, here's the new memo for today. How do you do this if people are working remotely? So thinking about what platforms you're going to use to share memos and documents and new protocols and procedures while people are remote. So thinking about things like Microsoft Office 365, or if you have, most of us do have a Microsoft Outlook platform, you can remote into that using a URL address. So thinking about, again, how do we share documents in this new world? And then also, when you're thinking about telehealth, how do you do routine, and in particular, preventative well care visits, like the well child check? How does that happen remotely? How does that happen through telehealth? And that really needs to be a conversation with your medical director, your chief medical officer. How are you doing those checkups in this telehealth world? What are the things that can still be done, and what are the things that can't? And so that is a conversation and a protocol that needs to be agreed upon within your organization. So telehealth services, when we think about the processes, are reimbursable by all the major players, so Medicare, Medicaid, and commercial plans. We know now that both the federal government as well as our own governor has really created flexible rules and regulations around this so that patients can be seen in their homes while providers are in their homes. And that is a game changer, of course. It allows us to maintain our social distancing. And so, as I said, right now we have 85% of our 200 employees working from home, doing all the work that they did, but doing it remotely. And just a little note that plans must reimburse for telehealth the same as a face-to-face encounter. That was in the governor's executive order. So the plans may not all be quite aware of this or agreeable to it, but it is within the executive order. So it is something that we need to be our own advocates for. So just wanted to talk a little bit about telehealth and sort of make sure we're using the same language here. So telehealth, there are many different forms and variations of how you can do telehealth. What we're primarily going to be talking about today is live synchronous video conferencing. So that is a two-way audio-visual link between the patient and the care provider. Again, live synchronous. There is also audio only, so there's no video component. That is also in the orders that have come out from, in the memo that has come out from both Medicaid for the state of New Jersey, as well as Medicare from the federal government, as well as the executive order from the governor. That both of these two forms are reimbursable at the same rate as a face-to-face visit. We can also mention there are asynchronous video conferencing, and this is used a lot by specialists. That's where I send, for example, an electronic consult to a specialist, to a cardiologist. They review it and they send back the information. That's asynchronous, it's not live, but that is also covered in the telehealth regulations. And there are other methods as well. I've just listed the top 3 most common. So telemedicine, telephonic is the audio only, and then e-consults, as I mentioned, are often the asynchronous form of telehealth. So again, when we think about processes that need to change, one of the things you really want to think about are remember the codes that can be used. And so because of a lot of the regulations have come out that they're the same as a face-to-face visit, your procedural codes will be the same. And if you notice, this table represents audio with a video component, and you're going to use the same procedural codes we currently use right now. But remember, there are separate telephonic codes that are not listed here that can be used as well. This table really is to represent that telemedicine is billable, and each payer may have certain modifiers or things you need to change in order to bill for the telemedicine. So again, this slide refers to the procedural codes we use, the CPT codes we use, and then this slide refers to those billing changes that may need to happen, that do need to happen on the back end. For example, place of service may need to be changed depending on the payer. And so my team has put together this grid as is shown as an example of how the place of service or the POS changes depending on the payer, as well as modifiers for telemedicine service that can be added on. So again, your billing team should explore this and put your own grid together of what are the various place of services depending on the payer that is required or the modifiers they are requiring. I will make this important note: for straight Medicaid, there is no place of service or modifier required. Straight Medicaid, Medicaid fee for service. And I know a lot of our behavioral health providers fall into that world. So nothing changes in that case. And there was a Medicaid memo that came out about that. So no change of place of service, no modifier needed. You basically bill it the same way you would a face-to-face visit. So what is the technology available for telehealth? And I'm sure, like me, your email has been inundated with everyone talking about the various platforms that can be used. The one that we have chosen is DoxyMe, and I like it for these following reasons. Number one, there's a free version, and there's also an inexpensive version. And given, I think, the reductions in productivity and revenue that we probably all are experiencing, the free version sounds really good right now. But you can upgrade if need be. It's fast and it's easy. Again, we need to be up and operational in days. So we changed our organization within 3 to 4 days. Our entire organization was up on the technology. It is straightforward to use for our patients, which is key, and providers. And it has an audio only capability as well, which is nice, because as I mentioned, Medicaid, Medicare, and the plans are reimbursing for telemedicine as well as telephonic services. And it also has a system to call patients from the platform. So again, providers or staff don't need to use their own individual phones. So for those reasons, I really liked that system. But again, there are multiple other systems out there. So that is my session. Again, thank you, and I'll be here for questions when it's time to take questions.
Thank you, Kemi, Dr. Ali, for that. And next we have our next speaker, Dr. Chalakani. I'm sorry, I may be saying your last name wrong, so please correct me if I am.
Thank you. Thank you. Thank you, everybody. And again, Tyla and Adelisa, thank you for having me today. And I'm in good company with Dr. Ali, and I appreciate her comprehensive overview. And when we look at physical health and behavioral health, there are very similar parallels there. So everything Dr. Ali shared is really the same as what we're doing in behavioral health. But as I address what's a little bit different in our world, I want to acknowledge that we've all had to rapidly change and adapt our practices in ways that we've probably never thought we would have to, and probably ways that are not very comfortable for us or for our clients. But the first thing we have to think about always when we provide services is obtaining consent. And telehealth consent does look a little bit different than traditional informed consent, because we really need to make our clients and patients aware that something is different. And first and foremost, especially in the field of behavioral health, we have to go extra steps to maintain confidentiality and privacy when we're providing psychiatry and psychotherapy and group therapy. And we need to let our clients know that we can no longer ensure their privacy the way we normally can, because we don't know who is in their home or wherever they may be receiving their telehealth services, so we cannot control that environment. And that's something that's very important to acknowledge when providing telehealth. We also need to discuss the fact that they may not use a public Wi-Fi, or they can do so, but it would be at their own risk, that their Wi-Fi should be private, because that's the only way they can ensure that no one else can interfere or hack into their telehealth session. And it's also important, and this is something that we probably don't think of, is that I myself, as I sit here, I'm wearing an Apple Watch and my phone is next to me, that Siri should be disabled on our devices. And if we use a Google Home or an Echo, an Amazon Echo, where we use Alexa, that also should be disabled, because those are potential breaches of confidentiality as we work in our home space. The other thing that's important is the environment. You know, can we provide an environment for our clients, or can they provide one that is quiet and feel safe? I know myself, when I've been working with private clients, I've gone into my office alone so that the surroundings look familiar to my clients when I'm able to do so. And I think it's important as well for we as behavioral health practitioners to let our clients know that this is uncomfortable for us as well. And this is new, and we're all learning as we go along, because something that I know I experience and I've been hearing throughout our community is that our patients and clients are uncomfortable, or they're shying away from these appointments. Sometimes it might be because they don't have the technology, but even when they do, they don't know what to expect. And the reason they're coming to us for behavioral health services is because they may already have an underlying issue with anxiety or a mood disorder. And this whole environment that we're living in right now is very anxious, it's very uncertain, and it's really important that, you know, even though we've had to make these rapid changes and they've been thrust upon us, and, you know, we want to get our sessions in and get people scheduled, that we all need to take a break and breathe and, you know, think about where are we really meeting people where they are. And Preferred Behavioral Health is a trauma-informed organization. So this is really a traumatic event. We're all sharing something at the same time. We're experiencing loss of life as we knew it. We're experiencing perhaps the loss of our health or loss of a loved one. And we really need to put that in the forefront of our minds before we even go about scheduling a session. You know, maybe a phone call first to check in and see how are you doing. I know that, you know, you have anxiety previously, and it must be that much more worse now that we're living in this very uncertain world. Talk to me about it. How do you feel about having a telehealth session with me? It's not my comfort zone either, but let's at least try it once. And if you don't like it, you know, we'll try to be creative. But it's really important that in the behavioral health world, that we first validate where the person is coming from before pushing this new reality that we're living in onto them as well. A question had come up, which I'll answer now before we open up the floor to other questions, is how do we know if our clients need more than what we're providing? And that can be difficult in telehealth. And I will be transparent that prior to COVID-19, I'm old school as far as my psychotherapy practice is concerned, and I've been very opposed to telehealth. I've had clients ask me for it in the past, and I've, you know, gently declined because it's not my comfort zone. I really like to share a space with someone and read their energy and their body language. And someone said to me this week that I feel like a surgeon who's lost their hands. And I can relate to that because I'm only seeing people from the neck up. I can't really read how they're feeling. Everything has to go in the session based on what they're sharing. But regardless of meeting in person or conducting a telehealth or telephonic session, the dialogue is typically the same. And as mental health clinicians, we should always be conducting a mental status exam. And if there is anything unusual or questionable, then there are other evidence-based tools that we use to screen our clients. So if they were suicidal, we would be using the Columbia Suicide Scale. If we thought they were having anxiety or depression, we would be using assessment tools to measure those symptoms as well. And again, whether if we're meeting them in person or if we're seeing them through a virtual platform, our steps are the same, you know, asking the proper questions and then referring them, whether it's to the ER or calling 911 or referring to a higher level of care as we typically would. So, I mean, we've all had to learn to be really creative and adaptable given the circumstances, but it sounds like Dr. Ali's experience has been positive, and I can share that at Preferred Behavioral Health Group, we serve over 30,000 people a year, and it's remarkable how we were able to rally and move to this seamless transition to telehealth. And in many programs, it happened immediately, but I can confidently say that within a week or two at most, everything was via telehealth. And we as an organization are using Skype for Business. We have a large organization and about 500 employees, and it's just really easier to stick to one platform than to use multiple. So we do use Skype for Business. It is HIPAA compliant. I know that there are other platforms out there that are as well, but this has been working very well for us. So I'm open to questions as we move forward regarding behavioral health specifically. And I thank everybody for their time today, because I know I've spent a lot of time in webinars and online platforms myself over the last month. And it's a wonder that there's 180 participants. So I thank you all for coming today and being willing to join us. And thanks again to the Healthcare Quality Institute.
Thank you both for that helpful information. It's definitely, you spoke about a lot of best practices, and I just had a couple of questions of my own before we open it up to Q&A. And I'll just say first, for those of you who are participating right now and have a question for either of our speakers, please type it into the chat box now. I see there's a couple of questions coming through already, and we will get to as many as we can in the time allotted. And so my first question actually goes to you, Dr. Ali. How does your staff train and troubleshoot with patients that have a difficult time accessing or using technology?
Yeah, and I think Tara mentioned it so well, that we have community navigators, community health workers, and so a lot of their responsibility is reaching out to the patient, walking further, asking them, do they want to have a telehealth visit? Are they comfortable having a telehealth visit? And helping walk them through the process. And so I think having individuals who can do that is really key, because this is a new ground for everyone.
And is that, just to clarify, is that troubleshooting with patients taking place ahead of that meeting, or is that kind of the first thing you're doing at the meeting?
So if you mean, so for example, if someone says they want to have a telemedicine visit at 2:00 tomorrow, then we are trying to reach out to them today and walk them through the process, make sure that they're comfortable, make sure they have everything they need, and troubleshoot whatever the issues are before they get into that virtual waiting room.
Thank you, and that makes sense, so that the actual appointment time is of most value to both you and the patient. And Dr. Chalakani, how do you determine if your patient has needs beyond what a telehealth visit can provide, and what are the recommended next steps if they do?
So again, with behavioral health, when a session is conducted, whether it's a psychological evaluation, a psychiatric evaluation, or a traditional psychotherapy session, peppered into the dialogue are questions, probing questions, trying to assess where the client is, and doing a mental health status exam, trying to understand where they are as far as their mood. What do they appear, or what do they sound like, or you sound really down, what's going on with that? More probing, understanding where they're coming from. And then if comments are made, like, for instance, I hope I don't wake up tomorrow. Well, that's our red flag. Now we have to probe a little deeper, see where they are, determine if we need to use an evidence-based suicide scale. So, as far as our session in our world goes, it's the same. It's different in that we're not sharing a space, a physical space with our clients, but as far as the way we conduct a session and how we assess and how we refer is really the same.
Great, thank you. And this question's really for both of you. How do you encourage patients to continue receiving their care through telehealth services?
Did you want to go for? I'll go. I can say confidently that a lot of clients have fallen by the wayside, where we've had to call them and re-engage them and try to convince them to return, because I think at first there was this sense of perhaps this was going to be a lot more temporary than it's feeling at the moment, being distanced and having businesses closed. But I think now that there's a feeling of this is going to go on a little bit longer, that treatment doesn't feel so optional anymore. And I think that our clients that have been connected with us realize that they really need this as a support to their mental health and their overall wellness as time goes on. But the biggest piece is really maintaining that connection. And I know that even when we first closed our doors and decided to work remotely, before we had our telehealth platform and consent forms, et cetera, securely in place, everything was being done by telephone, making sure that we were connecting with our clients. Are you okay? Do you have enough to eat? Do you have everything you need? And we're going to start doing our work via telehealth. And so I think maintaining that connection and not letting it lapse in any way is really the biggest piece as far as maintaining that connection and trying to alleviate any resistance or reluctance to engage in telehealth.
And
Thank you,
I,
Dr. Lee.
yeah, and I was going to say, I completely agree. It's all about the connection with the patients, and how do you continue to maintain that. And so I think as Dr. Chalakani is saying, it's really about not letting people drop off the radar. And we have to be proactive now. We really have to be proactive in reaching out to individuals, making those phone calls, connecting with them. We've done, of course, all the media things we can as well. So we put it on all our social media campaigns. We put it on our website. We've put out flyers saying that, if you have a need, we are still here for you. This is the way that you can get in touch with us. A lot of our electronic medical recording systems have texting options and calling options. And so we've used those blasting systems as well to reach out to all of the individuals within our system saying, we understand these are really difficult and challenging times, but we are here for you. Please reach out to us if you need us. And so again, I think us being proactive to stay connected, as the doctor mentioned, is what is going to be key.
Great, and that was a good point, particularly as this goes on a lot longer than we may have anticipated, continuing to let patients and families and others know that you're still here in the various ways and that they can kind of choose the method that works best for them. And with that, I think we'll open it up to Q&A. So I'm going to hand things over to my colleague, Tyler.
Great. Thank you both. Thank you, all three of you. We've gotten a lot of really great questions in so far. So keep typing them into the chat box or into Q&A, and we'll get to as many as we can. I'm going to offer the first question from Dr. Brito from the Nicholson Foundation. My understanding is that unlike synchronous telehealth services, e-consults are currently not billable. Is that correct? So I think that's for Dr. Ali.
They are not billable to us as the person initiating the e-consult, but my understanding is that they are on the specialist end. So for example, the specialist receiving that electronic consult can now bill for that service. So, and they can bill for that service. So it's billable on the specialist end, not on the primary care provider's end who's sending it out.
Got it. Another one for Dr. Ali, specific to the platform that you use, the Doxy Telemed phone service. Is that also available for mobile phones, or is it solely used on laptops or desktops?
No, you can. So all the other thing we like about Doxy is it does have a mobile friendly version. So patients can use it and they can receive the calls and they can see the video link on their phone, as can providers. So that's why I say it's really very facile and easy and friendly is the word I'm looking for to use.
Okay, great. Tara, I think this one's for you. Do you use telehealth for group therapy?
We do. We're also using Skype for Business and our intensive outpatient programs, both for adult substance use and adolescent services, are using it.
Great. And this question I think is perhaps for both of you, and one that we've gotten on almost every similar question on almost every single webinar that we've done, because I think more attention needs to be paid to the care for children. So how do you address, for both, either for therapy needs or for physical health, how do you address young children? Are there different things that you can do to make them more comfortable with this new format, knowing that they're probably having anxiety issues as well?
You know, I have to say, I'm a pediatrician, as I mentioned in opening, and so that's the one thing I love about children. They are so adaptable. They are so flexible. And, you know, for the most part, a lot of our children are using these platforms for school right now. So our first graders, our second graders, and so they're really getting very comfortable quickly with the systems. But I think, again, as was mentioned earlier, it's really about how do you find those connections through the platform. As a pediatrician, there are many things that I can do via telemedicine that are still very important. So a big part of what we do as pediatricians is neurodevelopment assessment. You know, are they holding up their head? Are they sitting up now? Are they eating appropriately? Can they walk now? Are they, you know, so those things you can still do. You can still assess those through audiovisual components. It's the laying on of hands that is the challenge. But a big part of what we do in terms of that neurodevelopment assessment in pediatrics can still be done. And those are the things that you don't want to miss. So I really do implore us, our primary care providers, not to forego a well child visit because we can't do the laying on of hands right now. So we don't want to miss a 6-month-old who may not be sitting up yet and wait 3 months from now till this is all over. So we really do have to think about what are the things we can do now so we don't miss some of those critical neurodevelopmental issues as this goes on.
And I'll just add from a behavioral health perspective that working with children always requires a lot of creativity. And so telehealth is no different from that. But I also agree with Dr. Ali that the children that we work with are very technologically centric. Most of the time they know more than we do. And but I mean, I can speak personally that when I've conducted sessions now with little guys, you know, they're excited to show their toys at home and their room or their pets. And, you know, whenever we work with children, we need to be where they are and kind of follow their lead. You know, we can't really force them where we want them to go. We need to build that rapport with them. And it's just a different way of doing therapy, but we have to, you know, use our skills and tap into where they are and what they have and be creative. I mean, that's what it's all about. And as mental health practitioners, we don't have the other piece of it, the medical piece of having to do a physical exam. So it's more about the dialogue and their mood and but it's interesting, but it's always fun. It's always an adventure working with kids.
Great.
I would just say one other note on this line. So we've also been exploring and getting into the world of teledental, right? And so talk about really hands-on. That's, you know, really hands-on. But again, exploring what are the things that we can do. How do we, as was mentioned before, how do we just stay connected with those patients? We don't want to go 6, 7, 8, 9 months without any connection with them. And it was interesting because we can do a lot of the pediatric dental exams are really just exams. And so our dentists have been doing that quite a bit, opening the mouth, say, ah, and, you know, take a look at all the teeth and make sure you're brushing twice a day. So they're doing that. And the interesting thing we found, as Dr. Chalakani mentioned, that, you know, you see what's happening in the background. And, you know, so our dentist started out seeing the child and end up seeing the family. So then the family's like, hey, wait a minute, Dr. Goodman, you're on. Okay, my tooth is hurting now, you know. And so it was really it's just a very interesting time.
That's great. And I'll just give a quick plug for a webinar that we have coming up. Registration is not posted yet, but we'll be doing that soon on April 22nd. We're going to be doing a webinar specifically on primary care and telehealth and making sure that people are not missing those appointments, like well visits, like, you know, monitoring chronic diseases, because they're so important and we can't spend weeks or months avoiding that care. So hopefully that will be helpful. Another really good question, how do you navigate language barriers? In the past, you would use an interpreter line. How can you, incorporate that into a telehealth visit?
And so that's why I like the most of these platforms. You can do groups just like this, right? So you rope in the individual who's going to be doing the interpretation. So we have people on staff, so you could potentially rope them in. But a lot of times you can combine 2 videos and 1 phone. So somebody doesn't have the video capacity, you can still use the interpreter. And a lot of platforms have that capacity where you can have multiple people calling in, or you call into the interpreter and you link them into that audio visual telehealth visit.
And we have a language line that we use at Preferred Behavioral Health Group. It's a dial-in, and it has hundreds of languages at our disposal. So that's still a resource that we can use even with the telehealth platform.
Yeah, I think the trick is just, all of us becoming savvy to do those group conference calls, not dropping someone off the line.
Right.
Yep, something we're all getting used to.
Right.
This next question, I think, is directed to Tara, but I think it's probably appropriate for both. If you have a patient that states that they're high on, that they may be suicidal and they are marked high on the scale that you mentioned, and I think this would go for physical health as well. If somebody is experiencing symptoms that are elevated, would you make a determination over telehealth to call an ambulance to their home?
Yes. I mean,
Yes.
we're always going to err on the side of caution, and safety is first. So would definitely be a 911 call. And I mean, we do wellness checks when we are working with at-risk clients and we haven't heard from them, and we've made every attempt to outreach them. So we don't hesitate to do that. And we would do the same in this circumstance as well.
Agreed. Same.
I'm going to switch over to Q&A for a sec and see what we have over here. So Tara, you mentioned that you use Skype for Business. Do they also have an online phone service for telehealth meeting phone calls?
You faded out for a second. You asked if they also...
For Skype for Business, do they have online phone services for those pre-telehealth meeting phone calls? I think that's so you don't have to use your personal cell phone, I gather is the ask.
Yes, there is a telephone option as well.
Okay, great.
Mm-hmm.
And this is a great question, and one that I think we're going to try to address with a future webinar as well. What do you do with patients who not only are having issues either accessing telehealth services or who may be uncomfortable? What do you do if they don't have a computer or a cell phone? How do you serve those people? That's something we're definitely going to address, but if either of you have suggestions.
So one of the things we've done and we're exploring doing is setting up a sort of computer location within our health center. So someplace that still allows for the appropriate distancing, but that they can use that so people can come into that location and access a computer, laptop, and provide and receive the telehealth services through those means.
And as far as we're concerned, I mean, we still can provide our services telephonically. So if they do not have a smartphone or a camera or a computer, we can use a telephone. However, we are looking at our budgets programmatically to see where there are surpluses where we can buy track phones. So we've done that in a couple of our programs where it's really more necessary that we have face-to-face contact with our clients. So we have done that, and I know that in our development department, they are looking for small grants to do the same so that we can provide our clients with the proper technology that they need.
Great. Yeah, we've heard from other Quality Institute members that they're doing the same. They're looking at creative ways that they can purchase telephones for some of their patients. So that's great advice. For patients needing either BMI or vitals, how do you do this via telemedicine for chronic diseases, for pediatrician visits, well visits, etc.? Yeah,
so this goes to talking about purchasing phones for patients. purchasing the equipment that they need. And so we were just exploring this last week, and we are looking for opportunities now, writing into all the grants that we can, in terms of how do you get scales for individuals. And then we have a pharmacy that does delivery. So we own and operate our own retail pharmacy, and now it does delivery services, so that we potentially have an opportunity that we can deliver things to individuals' homes. So we could deliver a scale, we could deliver a measuring tape, so a mom could, on the camera take the baby's head circumference. So we can deliver the blood pressure cuffs, the glucometers, and those things of those nature. So we're looking at that right now, putting those dollars together. What would it cost to give our high-risk patients the tools that they need so that they can do some vitals while they're at home? And we're thinking could potentially be such a huge win-win, right? Because now I'm the doctor. I'm going to show you exactly how to do it. I'm going to watch you do it. And now going forward. Now always how to take your blood pressure correctly, how to get your weight if you're a hypertensive and you need to monitor your fluid intake. If you're a mom and you want to, again, take your child's height and weight and measurements. And there are a lot of programs that are out there that show that this really does help our patients and families become engaged, right? So when you talk about centering pregnancy and centering parenting programs that are done nationally, that's what they do. The moms get together and they do the vitals of their babies, and they show that it really does help empower the parents.
Great. So many good questions still coming in. So we have about 12 minutes left, so we'll get to as many as we can. Any recommendation for keeping up with monitoring parameters when prescribing psychotropics to both new and established patients?
Kemi, I'll let you take that one since you're an MD.
And so I'm a pediatrician, so that's not my specialty. But I would say my first thought is not much is going to change, that how you monitor in the physical world should be the same, if not more. And it's all about continuing to stay connected with the individuals, making sure you have a plan of who is going to do that as you're prescribing them. Do you have a community health worker? Do you have a patient navigator? Do you have a nurse assistant, someone who's going to be tracking and reaching out to the patient regularly if you're going to do that in this virtual world?
This one's a great one, one that I have not heard yet. Many of our youth and their families are sharing devices, computers, phones, etc. They may have limited accessibility to a private space. I think we're all challenged in finding spaces in our house that are quiet, and as we're all doing, Zoom calls and things like that. What are some ways that you can help address privacy or accessibility concerns within somebody's space?
That is an interesting question. And so you're right, it's not one I've come across before. And I think you would, my first thought is really just sitting down and talking with the individual at first of where is a good space in your home to do this, walk them through where they think that place could be, and then helping them to problem solve as best you can. But that is a key issue. And even as a physician, we think about that with social distancing. If you're in a 3-bedroom apartment and one person is COVID positive, how do you social distance in that? I don't know if it's possible. And so again, thinking about how do you do telemedicine, telehealth in that world, I think you'd have to do the best you possibly can. And sometimes that may not be perfect. I think in this world, we're going to have to let a lot of perfection go in order to meet the critical need that's there.
So this is something, that's very relevant to behavioral health, because privacy is a must and boundaries are a must. And so this is really something that needs to be discussed at that time of obtaining the telehealth consent, because it really is important that no one else is in the room. I know some practitioners that I've spoken with, they have their client take their device, if it's their phone, and scan it around the room to show them that no one else is in the room. I've seen clients in their bathrooms. They're sitting in their bathroom for the 45 minutes to an hour that their session is, so that they can be alone with the door closed. Sitting in a car, obviously not if it's a child, not with the keys or anything like that, but so that they have a private space where they can talk and no one else can hear them. But it really is a discussion that needs to take place before services begin, and really, stressing the fact that as your provider, we're always there to be your advocate and to help you create healthy boundaries, and that this is no different. And we have to adapt to where we are, but finding that space. And even if you're in a tiny studio apartment, there's a bathroom. So if worst case scenario, or sitting out on your front porch, as long as no one else is around, I mean, we have to be creative, but really send the message that it's important, especially for behavioral health care, that the client needs to have a private session.
That's great advice. A couple of follow-up questions on group therapy. Someone commented that it's their understanding that the state has reported that they don't approve using telehealth for groups due to privacy and confidentiality on the client end. But we can look into that, or if you are aware, I don't know if that's something that's still billable. That might be the question.
It is billable, and my understanding is that initially that group therapy was not approved for telehealth, but then it now is. So, and yes, that's a concern, because we don't know if a group member has someone in their space that can hear what the others are saying. But again, it's something that's included in the telehealth consent. It is a potential risk as we provide telehealth, and it's something that needs to be discussed with the group facilitator. Just as any group, there's always rules, there's always boundaries at the beginning of a group session. So this is no different. These circumstances are no different.
Great.
Agreed. And I would also just, again, highlight that the governor's executive order was really clear that all services that were paid face-to-face must be reimbursed through telehealth. There were no caveats. There were no carve-outs.
Right.
So again, that's why I said the insurance companies may say one thing, but when you push back on them, which I have, it is quite clear that all services that were allowed face-to-face must be allowed through telehealth.
A couple of questions too about, again, sort of testing that would normally be done in person, but now sort of finding workarounds to that. One, are you doing urine drug screens for those who require it for addiction medication? How are you handling testing and assessment for that?
So again, creativity is necessary, and I know it's program specific. I mean, we have over 70 programs at Preferred Behavioral Health, which are adult, child, and substance use specific. So every program is functioning similarly, but yet individually at the same time. We're piloting an in-home recovery program with the Nicholson Foundation, and what our staff is doing is, wearing masks and gloves, packing up urine drug screen cups, dropping them off on a doorstep. The parents are testing themselves and holding the cup up on screen after they've gone to the bathroom in private and displaying the results. We're also looking into new technology, which uses smartphones, and they take a saliva sample and give instant drug screen results. So we're constantly moving forward and thinking out of the box and looking to pioneer new and revolutionary ways of doing things. Because I mean, again, initially no one knew how long we would be physically apart and unable to provide physical services. But now as the time stretches longer and longer, we really need to think out of the box.
And then lastly, we'll just do one more question. I got a couple of different questions, same topic. If either of you could elaborate on how you obtain consent for any type of session, whether it be physical or mental health.
So and I think that the doctor had mentioned it before, but it's verbal. So it's a verbal consent process, and you document in your note that consent was verbally obtained. And I do see too, this issue of confidentiality in the licensing office and HIPAA regulations. HIPAA and most of the offices have again reduced or are more flexible with their regulations right now during the pandemic. So this is, one time only, but during the pandemic, sort of all the regulations are gone. So you could use FaceTime for your visits. I don't know if any of us would, but you could, because during the pandemic, all of the requirements around confidentiality have been relaxed because they know it is a challenge. They know the difficulties that are out there right now. And so if you go to the HIPAA website of the federal government, it talks about the regulations being relaxed during this time of COVID. So again, I think a lot of the confidentiality rules and regulations that are in place federally and within the state have been relaxed specifically during this time of COVID. But we do get verbal consents for everything where we used to get the written consent.
Got it. And yeah, I think there's going to be
converted our written consents to an electronic online document that if a client has the capacity to access a computer, they're submitted electronically. And we also have are doing verbal consents and then documenting it as well.
great. And Tara, is there a specific program for the electronic consent that you use?
We use Cognito forms.
Okay.
That's how we convert all of our documents to an electronic document.
Okay, great. Wonderful. Well, we have about 2 minutes left, so I'm just going to share my screen quickly and share with everyone some information about some resources that we have. At the Quality Institute, we created a guide to telehealth in New Jersey that this is just the first page there, but I'll give you the link to get to it on our website. And it has some helpful information about making sure that you know how to access telehealth and what all of the insurers are covering at this point, to Kemi's point. Our next webinar, registration is open now for that. Thursday, April 16th from 12 to 1. Again, we're going to be talking about being prepared. It's a topic that is something that we work on through our Conversation of Your Life program throughout the year, but is especially important now. Being prepared, so having advanced care planning conversations at home with your family, making sure that they're aware of your wishes. In your community, we have county task forces all across the state that do this work. And then also with your provider, making sure that your wishes are documented. So a really important conversation right now, and we're going to have Tacey, who heads up one of our task forces, to talk about that work in the community, and Dr. Sharma from VNA Health Group, as well as Centra State, to talk about how to talk to your provider and how a provider can talk to a patient. So the objectives are there. I hope you'll go to our website and our events section to register for that, and we'll send out a link as well following this presentation. And then lastly, the recording from today, as well as Dr. Ali's slides, will be available on our website. Adelisa mentioned it before. It's www.njhcqi.org. You can't miss it. It's right up at the top, our COVID-19 resources, and then the short link is there for you at the top as well. We have put together the telemedicine resource that I mentioned, a new advanced care planning resource, as well as several webinars that we've concluded already, and are doing webinars each week on different topics. So I hope that you'll visit the the COVID resource section rather to view all of our new resources. And so with that, I just want to thank Adelisa, our Director of Quality, for moderating today, and Kemi and Tara for all the wonderful information that you provided. We really appreciate it, and I know this topic is huge for everybody right now, so we'll be following up with all of these resources and making sure that everybody can access all the great content that you provided today. So thank you so much for your time.
Thank you.
Everybody
Take
for
care.
joining.
Thank you, everybody.